Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Organon.
Good morning, Maya and Mrs. Rodriguez. It's been about 6 months since I last saw you both. How have things been going?
Okay, I guess.
Well, doctor, we've been managing, but honestly, I'm not sure we're doing the right things anymore.
Tell me more about that. What's been concerning you?
We stopped the steroid creams like you said we could try about a year ago now. I was doing so well for a while, but the itching came back.
It's not as bad as when I was little, but it's still annoying. See, it comes back in the same spots.
I can see some mild inflammation on your arms here. And Maya, I noticed that there's some darker spots on your legs from where the eczema was before. How often would you say you're bothered by itching?
Like, every day, especially at night. Sometimes I wake up scratching.
And that's the thing, Dr. Miller. I feel like we're back to square one. The moisturizing routine, the special baths, watching what she wears. It takes so much time, and I'm wondering if we're missing something. Is there something easier we could be doing?
It sounds like you're both working really hard to manage this. Linda, I can hear the frustration in your voice about the daily routine, and Maya, it must be difficult having that constant itch.
I just wanted to stop coming back in the same places.
Exactly. That's what I don't understand. We'll get it calm for a few weeks, then boom, right back to the same spots on our arms. Are we doing something wrong?
You're not doing anything wrong. Actually, what you're describing, the eczema returning to the same locations, it tells me that we need to think about a different way to keep those areas calm. Let me ask you this. What are your main goals for Maya's treatment right now?
I just want something that works but isn't so complicated. And definitely no shots. Maya is terrified of needles.
No shots.
No shots, understood. Okay, let's talk about some options that might help prevent those flares from coming back in those same spots.
Hello, I'm Dr. Adelaide Abear from the University of Texas, McGovern Medical School in Houston, Texas, and I'm happy to be with you today to discuss building the case for nonsteroidal topical atopic dermatitis treatments. We're excited today that we have a case that we've shared with you. Her name is Maya, and she's 10 years of age. Let's talk about our learning objectives today. First question is, what are the factors that you would consider when you're assessing the severity of Maya's atopic dermatitis? I would certainly think about the disease distribution. She's got facial involvement, which is particularly disconcerting for a child that's age 10, or really any child with atopic dermatitis. She also has significant disease burden on other body areas, including the legs. And post-inflammatory hyperpigmentation has developed, so there is ready visibility of what her disease has so there is ready evidence of how this disease has impacted her, and it has impacted her for quite some time. Next, we really want to consider the signs and symptoms of atopic dermatitis. What do you look for in a clinical diagnosis? We know that atopic dermatitis truly is a diagnosis that is based on clinical findings. We really don't do laboratory tests or other metrics in order to ensure that we have the proper diagnosis. We see the patient in front of us, we ask a few questions related to itching and overall impact of the disease, and we can generally make the diagnosis correctly in that moment. We also want to think about parameters such as the body surface area involvement, as well as the investigator's global assessment. Does this patient fall into the category of mild, moderate, or severe. In Maya's case, she certainly, in my opinion, would fall in the moderate category. We also want to think about arenas such as the impact of atopic dermatitis on the quality of life. Here is a child that has been long suffering. Her family is concerned. Her mother expresses worry regarding the child's itching, her inability to sleep, her discomfort, as well as the post inflammatory hyperpigmentation and the evident spongiatic dermatitis. So we have many factors to consider in Maya's overall well being, and we can use these factors to prepare a therapy that would be appropriate for her. We really want to think also about the disease burden. The impact of the atopic on dermatitis on quality of life is such an important consideration. We have to think about the psychosocial impact of atopic dermatitis. We know because of lack of sleep, these children may not perform well in school. The behavior problems that may develop because they have not rested effectively during the night. We also know that there are costs to caregivers, and that includes not only the financial burden of the prescriptions, the doctor's visits, the moisturizers, the washing of clothing on a repeated basis, but also missed days from work as well as from school. We also recognize the fact that there are many unmet needs with regard to atopic dermatitis treatment. While, of course, our patients and their caregivers would like us to have a cure, we're not at a state where that can be offered at this time. We know that our patients and parents also want a very simplified regimen, and they want to be able to perform the therapeutic impact, they want to perform the therapeutic components of care in a timely fashion that is not a great burden to the family or to the patient themselves.
So let's explore some options that might work better for Maya's situation. You mentioned you wanted something simpler. What does that look like for you?
Honestly, something we don't have to apply multiple times a day would be amazing. And I've been reading online about steroids in kids, and the side effects made me nervous. Are there alternatives that aren't steroids?
That's a very common concern, and I'm glad you brought it up. The good news is we now have several non-steroid options that can be very effective for Maya's type of atopic dermatitis.
On steroids? What does that mean?
Great question. It means these medications work differently than the steroid creams you used when you were younger. They help calm your skin's itchiness and redness without some of the concerns your mom has about long-term steroid use.
Okay, I'm listening. What are the options?
Well, for Maya's age group, we have a few excellent choices. There's tapinarof cream. It's approved for kids 2 and older, and it works really well for the type of persistent areas that Maya has. It's once daily application.
Once daily? That's much better than what we were doing.
Exactly. We also have roflumilast cream, which is also applied once daily, but it can be very effective and is safe for use on the face and body of children your age. Then there's crisaborole ointment. Some families really like the texture, and it's also twice daily.
Can I use them on my face too? Sometimes I get itchy spots near my eyes.
Yes, Maya. All of these can be used safely on your face and body, which makes things much simpler. No need to remember different medications for different areas.
How quickly do they work? With the steroids, we'd see improvement very fast, but then, well, you know how that went.
That's a great question. These work a bit differently. You might start seeing an improvement in about a week, with really good results by 4 to 6 weeks. They're designed for more long-term control rather than quick fixes.
6 weeks? That seems like forever.
But honey, if it means we don't have to keep starting over every few months.
Maya makes a good point, though. The trade-off is that once these medications start working, they can help prevent those flares from coming back to your arms. Think of it as training your skin to stay calmer.
Wait, so this could be like maintenance to prevent the flares rather than just treating them?
Exactly. That's the key difference. We can use these medications proactively on Maya's trouble spots, her forearms where the eczema keeps returning, even when her skin looks relatively clear.
So I wouldn't have to wait until it gets itchy or red?
Right. We treat those areas regularly to keep them calm. Now there's one more option I should mention, ruxolitinib cream. It was recently approved for kids in your age group and older, so it's another medication we could consider. This one does have to be applied twice daily, but in children your age it has shown good results for controlling eczema severity and reducing its appearance on your skin.
It sounds promising. Which one would you recommend for Maya specifically?
Well, let's talk about what would work best for your family's routine and Maya's specific needs.
Our next learning objective really deals with what do you think the most appropriate treatment for Maya would be at this current time? And we know we have a number of modalities in the topical arena now that are available for patients who are in Maya's 10-year-old age range. I'm going to start off with tapinarof. We recognize that this is an aryl hydrocarbon receptor agonist, and we had some data, particularly dealing with the validated investigative global assessment at week 8. As you can see from the two studies that were part of the pivotal trials, the Adoring 1 and Adoring 2, that we did see a greater improvement in those patients randomized to tapinarof as compared to those patients randomized to the vehicle arm of the study. I think the pictures are the most telling component of this slide, and you see at baseline the erythema and spongiotic dermatitis in the popliteal fossa, whereas by week 8, we see resolution of the spongiotic dermatitis as well as the erythema. So a very favorable outcome. This patient went from a validated IGA score of 3 at the beginning of the study all the way down to a validated IGA score of a 1 by the end of the 8-week time course. This was once daily application and no concurrent use of moisturizers in the treatment areas where tapinarof or the vehicle was used. So a very favorable illustration of how effective this medication can be once daily in the management of mild, moderate, or severe atopic dermatitis. We look next at itch improvement during the course of the Adoring 1 and Adoring 2 studies. And as you could see from these graphs, that the blue lines representing tapinarof demonstrated a statistically significant improvement over that was construed in the vehicle arm of the study. So quite remarkable improvement in itch when tapinarof was applied once daily to the areas of atopic dermatitis. The vehicle arm, while they did get some improvement, they did not have the overall outcome that was as favorable as the tapinarof arm of this clinical trial. We see also with roflumilast that patients can undergo an investigative global assessment that demonstrates improvement. Now, roflumilast is a PDE4 inhibitor, and this was a 4-week study with once daily application. And as you can see from both the bar graphs as well as from the clinical photos, these patients did have a very remarkable improvement in their overall response to once daily roflumilast applied to the areas of spongiotic dermatitis. Again, this was once daily application, and this was a 4-week study. You can see that the patients went from the IGA of 3 in the top slides all the way to an IGA of 0. In the lower slides, you can see that again, the patient went from a validated investigative global assessment of a 3 down to a validated investigative global assessment of a 1 over the 4-week, once daily course of, of roflumilast application. Very nice data to share with you. Looking also at itch improvement with roflumilast, here we go out to a 28-day time course, and we can see that roflumilast outperformed the vehicle arm of the study in this clinical trial. These data really demonstrate the great efficacy of this PDE4 inhibitor in controlling itch over an extended time course. And we also note that not only did the patients improve rapidly, but there was sustained an even greater improvement as time went on. In the studies that dealt with ruxolitinib cream, a topical JAK inhibitor, we can see from the investigative global assessment improvement, there was improvement compared to vehicle regardless of the age group studied. All had an improvement over the course of the clinical trial with topical ruxolitinib. Keep in mind that ruxolitinib does have a BID indication for use in moderate to severe atopic dermatitis. Now, if we look at itch improvement, We can also see over a 56-day course, we indeed have not only rapid onset of itch relief, sustained itch relief, and even ongoing improvement in itch relief over the 56 days with regard to this particular clinical trial. So, very nice improvement, 56 days demonstrating itch improvement with BID application for moderate to severe atopic dermatitis. We can also see when we look at the numeric rating score for itch on the right side of this slide that regardless of the age of the patient, they did improve more favorably if they were randomized to the ruxolitinib arm of the study compared to those who received only the vehicle drug as part of this clinical trial. So we have a number of key considerations for the new topical treatments that are available for atopic dermatitis here in the United States. We know that we can allow simplification of the regimen of treatment because each of these drugs is available for once daily application. We know that as maintenance therapy, each of these therapies can provide adequate therapy, safe therapy, as well as efficacious therapy. We think simplification of the regimen with an agent that can be used once a day on all body surface areas really provides an improved treatment arm for this particular patient to receive. We believe that Maya, as well as her parent, will approve of this regimen because it does offer effective therapy that will be well accepted, well tolerated, as well as exceedingly effective.
Dr. Miller, I'm 10 now. I think I'm old enough to put on my own medicine. I don't want Mom to have to do everything for me anymore.
That's very mature of you, Maya.
Oh, but it better not sting. Some of those creams we used before burn when I put them on.
Maya, I love that you want to take charge of your treatment. That's really important, and you're absolutely right to be concerned about stinging. Let's make sure we pick something comfortable for you.
But doctor, I'm getting a little overwhelmed with all these options. And as I mentioned earlier, we really don't want to have to juggle multiple medications, one for her face, one for her body. We've done that before and it gets too confusing.
Linda, I completely understand that concern. The beauty of these newer medications is that they're all approved for both face and body. So Maya would only need one medication.
Really? Just one? And I can put it on myself?
Absolutely. Now, let's think about what would work best for you, Maya. The tapinarof cream is once daily, which might be easiest for you to remember. Most patients don't report stinging or discomfort with it.
Once a day does sound manageable for a 10-year-old to remember.
What about the texture? Is it goopy or gross?
It's a cream, so it goes on smoothly and goes into your skin well. It's not sticky or greasy. Maya, would you prefer to apply once a day or twice a day if it meant even better control?
Once a day. I want to put it on after my shower in the morning.
That actually fits perfectly with our routine. But what about side effects? What should we watch for?
The most common side effects are mild, maybe some temporary redness or irritation when you first start applying it, but that usually goes away. Maya, if you notice any stinging or burning, you'd tell us right away, right?
Yes. I'll pay attention to how my skin feels.
And insurance? Will this be covered or are we looking at a big expense every month?
That's a great question. Sometimes we need to work with specialty pharmacies to get the best coverage. My staff can help you navigate that process and find patient assistance programs if needed.
So if I use this every day on my worst spots, they won't keep getting itchy and red in the same places?
That's the goal, Maya. Instead of waiting for itching and redness to come back and then treating them, we're going to keep those areas calm and healthy.
This is the first time in years I feel like we have a real plan that Maya can manage herself.
I like that I get to be in charge of my own skin. When can we start?
I'll write up the prescription today. Maya, you'll start with the tapinarof cream once daily on your forearms and any other areas that tend to get bad repeatedly. We'll see you back in 6 weeks to see how you're doing. If we aren't seeing the expected results at the follow-up visit, we can explore roflumilast or ruxolitinib cream.
Cool. No more getting upset with complicated medicines.
Thank you, Dr. Miller. This feels like a promising plan we have here.
I'm hopeful it will help Maya too. Maya, remember, you're the expert on your own skin. Pay attention to how it feels, and we'll change things if we need to.
I will. And Mom, you won't have to worry about taking care of anything.
I'm proud of you for taking this on, sweetheart.
I'll have my nurse go over the medication instructions with you both, and we'll get that prescription sent to a pharmacy that can help with coverage and understanding anything you should be aware of with this medication.
Thank you, Dr. Miller.
Thank you.
Given that we've discussed some of the therapeutic options for Maya with regard to managing her atopic dermatitis, we need to then consider how we are going to monitor her for treatment success. Certainly, I'd like to see the patient back in clinic within a few weeks or months' time to see them personally. If the patient's parents feel that they're doing exceedingly well and their spongiatic dermatitis and itching are under control, I might arrange a telemedicine follow up. We could certainly see the patient back if adverse events are reported. We want to assess the patient to see if they've developed any secondary infection, they're having challenges related to compliance, or perhaps importantly, we have to make sure that the patient was able to actually acquire the medication in the first place. We know that insurance challenges can place a burden both on our offices, but also on the patients and parents who are trying to get the medication. Hopefully, each of you have learned about important resources in acquiring each of the medications that I've discussed with you today. These resources can be very helpful in making certain that our patients do indeed get the medicines that we feel that are best for their management of atopic dermatitis. I want to thank each of you for participating in this educational activity today. I hope that the discussion was meaningful for you and for your patients as well. I ask that each of you please continue on in the program in order that you can answer the questions that follow and that you can complete the evaluation for this program. Thank you once again for attending.